Good afternoon, America. It's straight up 4 o'clock on the in the Mountain Time, which means 6 o'clock on the East Coast, 3 o'clock on the West Coast, and I'm Dr. Randy Fink. Good afternoon or evening, as it may be to you, and welcome to Fertility with Fink and Friends. I am Fink. You are friends, and it is so nice to see you all here. Happy New Year. I hope it was a wonderful holiday season for you all. And here we are on January the 2nd. Great to be with you live from Colorado Springs. I am the clinical director of IVF services here at CNY Fertility, Colorado, and also the medical director at the Miami Center of Excellence in sunny South Florida. Happy to see everybody. We've got, we've got LinkedIn and Facebook right here in the middle, as well as YouTube. And we've got a couple of different Instagram feeds, mine over here, Randy Fink MD, and CNY Fertility right here. And so let's see, I see a lot of folks joining us here. Hello to Kira and Lisa and Siciliana Melissa. A very special hello to Bama Gal, who is none other than my beautiful mother, sitting with my beautiful father in lower Alabama, as we say. Hello to Mrs. Vince. Nice to see you here. And in fact, I would say, I usually like to acknowledge the people who are the very first ones to log in. Looks like my own mom wasn't enough on the ball today to join me as number one. You will always be my number one. Hello, Alpha Femme. Hello to Storm and Mio Angel and Big Auntie 4. Hi to Jenna. Good afternoon to you and Kaylee. And Macro Mama joining us first here was Lynn's 2528. Thank you so much for being here today. Still waiting for what looks like we've got some people on the Facebook side who have yet to say good afternoon. But so what was your New Year's resolution? What are you thinking? What are you hoping for? I will tell you that happiness seems to always be an elusive thing. It's very easy to lose sight of the little things and those things that are important. And so I would say that my New Year's resolution is about trying to really find those happy moments in all those little things in life that so often seem to zip right by without us even knowing. How many times do you drive home after a day at work or wherever you are, and you don't even pay attention to the fact that the sun is setting right outside of your window, right in front of you there, or that you got that special text from a friend just for no other reason than to say hello, or I was thinking about you. It's those little things in life that really make all the difference in the world, I think. And my hope, both for myself and for everyone, is that we can come to appreciate those little things and how those little things make such a big difference in our lives on a day-to-day basis. It's so easy to lose sight of what's important. And especially in this fertility struggle, when we're working on, thinking about and worrying and trying and waiting and how it really can suck the joy out of what we do on a day-by-day basis. And so, that's my New Year's resolution. I spent a few days. I got a nice little week off last week and got to spend some time with some beautiful family in Breckenridge, Colorado. Went on a little ski trip there, got a little exercise in, and I'm still in one piece. So I suppose that's a plus, gentlemen of a certain age. We're just happy when we can, walk up the steps at the end of the day. Let's see. We do have a couple of folks saying hi there. Hi to Mika and hi to Ludi over there on the Facebook side. Tamara is with us, or Tamara. Good evening. I'm almost 10 weeks pregnant and have concerns about when it is to go off the progesterone and oil. Most recommendations indicate 10 weeks. Is it harmful to stay on it until 12 weeks just to be certain that the progesterone levels are maintained? And what level should progesterone be when tested at 10 weeks or 12 weeks or 14 weeks? Well, so progesterone is the hormone that most importantly maintains the pregnancy. In the beginning, Well, so under normal circumstances, let's say natural circumstances, when sperm comes together with egg, the egg is being released from the ovary, and the space that's left behind in the ovary from where the egg is released is called the corpus luteum. The corpus luteum, pardon me, is what manufactures your progesterone. So in nature, it's that corpus luteum that's making the progesterone that continues the pregnancy ongoing. And that happens until about 9 weeks of pregnancy when the placenta takes over for the manufacture of progesterone. So that's why typically we say at 10 weeks of pregnancy, it's safe for you to be able to come off of the progesterone and oil because your body should be making enough progesterone at that point to maintain the pregnancy. That's where it's coming from. Before that, if you were to stop the progesterone, generally speaking, if you did a medicated cycle for an embryo transfer, you've got no other source of progesterone and the pregnancy will end. So it's a little different in a natural cycle or a modified natural cycle, but in a medicated cycle, we're giving you all that progesterone until such a time as the placenta will take over. So, is there any harm to staying on progesterone after the placenta has taken over? No, I wouldn't say there's any harm. I'm not aware of any data that suggests that getting too much progesterone is problematic, but the body is making it itself. And really, what we're looking for is a progesterone level that's above a 20, progesterone level above a 20 if you've had a medicated cycle. And I would say that that's probably really the same at any point, whether it's at 10 weeks. I'm not sure that there are norms established at 12 and 14 weeks, but we're looking at the minimum of 20 with a medicated cycle or 10 with a natural cycle. And really beyond that point, you could also ask the question, well, maybe I want to stay on it through 12 weeks. Well, okay, but how did you pick 12 weeks? Why not 14 weeks? Why not 20 weeks? Where does it end? The body is supposed to take over. The placenta is supposed to take over at about 9 weeks. So by 10 weeks, that should be the case. It is the case. That's what the placenta does. But so when do you draw the line? You're going to pick an arbitrary number of 12 weeks to say, oh, I'd like to stay on it until 12 weeks. I think the placenta is doing what it's supposed to be doing. So whether it's 12 weeks or 20 weeks, you're relying on the body to take over at that point. So that's a very good question. Let's see. Ashley is here with us. You all did my egg retrieval this morning. Outstanding. You and your staff were amazing. Thank you all so much. Ashley, thank you for saying such nice things. I hope you are feeling better today. So I always tell people that, hopefully you feel like, going out to dinner that night. And so I hope you will be able to go out to dinner tonight. And thanks so much for being with us today for your egg retrieval. We've got Jessica here as well. Do most people opt to do a frozen transfer instead of a fresh embryo transfer? Well, I will. Oh gosh, and Kelly is here too. Kelly says, I just had my egg retrieval with you this morning. Boy, this is like it's like a reunion this afternoon. How very nice to see you both. I hope you're feeling well. I do want to get to your question there, Jessica. Do most people do a frozen versus a fresh transfer? Well, at CNY Fertility, the fresh transfer is included in the price. So it's included in the cost. You don't pay extra to do a fresh embryo transfer. But there are some circumstances when we tell you we don't want you to do a fresh transfer because when your body has really gotten into egg making mode, that may be completely inconsistent with being pregnant mode, right? So you've done such a good job of making eggs. The hormone levels are such that your body becomes really not as hospitable to being pregnant, to receiving that embryo and allowing that embryo to grow. And that's why across the board, a frozen embryo transfer is always going to have a higher success rate compared to a fresh embryo transfer. Now, people do get pregnant from fresh embryo transfers all the time. In fact, I imagine there's probably 100 people on here who are watching who have gotten pregnancies from fresh embryo transfer. So, yes, it absolutely can work. But the success rate is higher with a frozen embryo transfer because of that reason, that the body is less thinking about making eggs than it is being pregnant if you wait and do it later on in a different cycle. But the fresh embryo transfer is included in the price. And so therefore, I would say still probably most people do at least attempt to do a fresh transfer. But if you look at our success rates, they will always be higher with frozen embryo transfers. And because of that, there are many clinics that don't even offer fresh transfers, that it's all a frozen transfer. They don't give you that option. And that's the reason why. However, as I say, people do get pregnant with fresh transfers. So as long as the numbers support it in our system, we will certainly allow you to do that. So, hi to Sarah. Mika is asking, which location are you at? I am here in the beautiful, scenic Colorado Springs. Of course, we have locations in 3 in upstate New York, in Syracuse, Buffalo, and Albany. And we have our location in Sarasota, which is now up and running full stream ahead. I hear great things happening from that beautiful facility down there. My colleague, Dr. Kondrup runs that facility, and so I hope you'll have a chance to visit there as well. I'm partial, of course, to Colorado. I moved to Colorado from South Florida and still go back to South Florida sometimes in Miami and in the Florida Keys. But Colorado is a very beautiful place. But yeah, I do miss Florida. Let's see if we can get some questions over here. Happy New Year to you, Dr. J, and to Nikon Cram. Hello to Brandis, our wonderful nurse practitioner, has joined here. Brandis ran the shop here during the week that I was out of town. So a great job there, Brandis, and for all the social media that comes out of our location. Brandis is our producer and coordinator. Mayfer 72022. So thankful for CNY and the Syracuse team. I am 2 weeks and 1 day post transfer, and my second beta is 734. Woohoo! Well, that is fantastic. And that's a good positive beta there, my friend. So sounds like 2024 is going to be a mighty special year for you. So congratulations. Hey to Carly, glad to see you here. Over on this side, on the other Instagram side, this is CNY's Instagram. Jenna says good afternoon, and Genuine ad Alberto, I think is what that says. Let's see what we got going on over here. When would you recommend, this comes from Frenchy Tango, when would you recommend starting Lovenox and Prograf? So Lovenox and Prograf are both medications that are part of our immune protocols. And in pretty much every scenario, with some rare exceptions, the immune protocols don't need to be started until really cycle day 1, the beginning of the cycle, when you are going to be doing your embryo transfer. Both of those medications are really more important for embryo transfer than they are for retrieval. And so I would say when you're ready to do your embryo transfer, your period starts, that's when I would want you to start on your Lovenox and your Prograf as you're working up to the point of the embryo transfer. Hi to Mahogany and Melissa Marie. SC Volt, boy, forgive me for that, for not being able to pronounce it, but hello to you too. We're going to see Jenna Marie Culkin is 9 weeks on Monday. What happy news. Congratulations. Oh, that is a wonderful to hear. Melissa Marie asked, when you have an early miscarriage, when are you able to actively start trying again. So really, it's once your beta is negative, and when you talk about the early miscarriage, it kind of depends a little bit on what the scenario was and what you were doing. If you had done IVF or an IUI, then we were following you very closely. If it was a spontaneous pregnancy, and you know that the pregnancy has ended, really what we want is for you to wait until, in that situation, until you have your first normal period. So in a spontaneous pregnancy, your beta will drop down. If you're following it, you'll see that happen. Beta, of course, is the pregnancy test. Then basically what happens there is that eventually you will get yourself a period. Once you have that first normal period, you are fine to resume trying. If we have done something to get you pregnant, so let's say that we've done IVF, we did an embryo transfer, and unfortunately, that transfer resulted in a miscarriage. Situation there is that we're either going to treat that pregnancy loss or we're going to follow that beta down to zero. Once it has gone away, you'll have a period there as well, and then you can resume. Now, we used to tell people that we would like for you to wait for 3 weeks, or 3 weeks, I'm sorry, that we would recommend that you wait for 3 months before you get pregnant. There is no truth to that. There is no data to support that. And someone that tells you that is kind of just basing that on, well, it sounds like a good idea. And that kind of used to be the recommendation because it was the common lore. Now we know that once you have that first normal period, you are fine to resume. If you get pregnant again before you have that first normal period, there is an increased risk for another pregnancy loss. So for that reason, that's why we want you to be able to wait. That 3-month number, when we used to tell people we want you to wait 3 months before you conceive after having a miscarriage, that 3-month number comes from, it's sort of a confused little thing that comes from, well, you're supposed to be on a vitamin with folic acid for 3 months prior to conceiving. Okay, well, that makes sense because that decreases the risk of certain types of birth defects, spinal birth defects, spina bifida to be precise. But as far as pregnancy goes, go ahead and get pregnant. And our fingers are crossed for you there, Melissa, as well. And Shauna says, oh, that's a good New Year's resolution. A baby is what I'd like to see for 2024. Oh, yeah. Oh, hell yeah. Macro Mama says 2024 is the year I finally get pregnant after 6 years of infertility and planning to come see you guys in Colorado Springs. We will look forward to having you. And this is your year there, my friend. Absolutely. And if an IUI, this comes from Megan, was successful the first time, is it more likely to be successful again? I miscarried at about 6.5 weeks, and gosh, Megan, that as I say, I hate to hear stories about miscarriages and people who have had to undergo fertility treatment because it is such a it's such a kick in the butt. It's just so not right. It's so unfair the way that happens. So my thoughts are with you for sure, and I'm so sorry you had to go through that. So what that tells me is that you did an IUI, an intrauterine insemination, and therefore, and it was successful. So what we know is that the system works the way it was supposed to. Right? That means that your brain talks, your uterus listens, the ovaries respond, the tubes are open, the cervix does what it's supposed to do with cervical mucus. The whole system is functioning correctly so that sperm was able to meet egg and you were able to have an implantation. You got a half step to where you wanted to be. That tells me the system works. The problem is with an IUI that I guess your question is it more likely to be successful again? I would say no, it's not that it's more likely to be successful again, but it did work once, which tells me that it can work again. So, the percentage of pregnancy from an IUI is probably around about a 9% chance or so of a pregnancy per cycle. per cycle, per menstrual cycle, or per month. We don't always, really encourage IUIs over IVF because IVF is the fastest and most reliable path to a pregnancy, with up to a 60 or so percent chance of a positive pregnancy test per embryo. So that's an order of magnitude higher than that 9% per cycle. But sometimes that 9% per cycle works. And really, honestly, in that situation, it's either 100% or zero, right? It's either going to work or it's not. The fact that it worked in you tells me, sure, I absolutely think it's worth doing an IUI again, because we know it worked, because we know that the hormones are working, that your body is capable of implanting and growing a pregnancy. So in that scenario, I would see no harm to you doing another IUI. Hello to April and to Colette. Most Creative Girl has joined us here. Skittles has a second consultation tomorrow. Good, very happy to be talking to you tomorrow. What happens, Skittles asks, if your cycle starts before you guys have all the blood tests? Can we start off before then, or would I be out of this cycle? Well, Skittles, it kind of depends on exactly what you're doing. Because if you're doing IVF, there's a question about clearing all the finance stuff, about getting all the medications in your hand, about having all the monitoring set up, and so forth. If you're doing timed intercourse at home with some letrozole, and you have the letrozole in hand and your period started, then it ought to be fine to proceed. If you have not yet been established as a patient at CNY and you go on and you've started your cycle and you have a consultation tomorrow and you really want to start IVF this cycle, I would tell you that part isn't going to work, unfortunately, because it does take a little time for the wheels to be able to turn. There are lots of folks kind of waiting in line for their to start their stimulation, and so we can't cut that out. So typically after the consultation, it usually takes about a week or so for our global team or even for one of the local teams to connect with you and set up the monitoring and make sure that everything is set and ready to go. We get your blood tests and the other testing that we're doing. And then when you have your next period, we start. Now, the other thing, Skittles, I want to mention to you there, again, depending on what you're doing, and I'm not sure what you're doing for treatment, but part of the usual evaluation that we will do for you is to evaluate the uterine cavity, typically with a saline sonogram, because we want to know that that uterine cavity is healthy and normal and doesn't have anything mechanical that's going to be an obstacle that keeps a pregnancy from being able to implant. If you haven't done that procedure, that test yet, I would recommend that you do not start your treatment, because I don't want you to get in a situation where you're putting an embryo back inside your uterus until that uterine cavity has been evaluated. I think that's a very, very important thing that's oftentimes overlooked, where people say, well, you know what, I'm sure my uterus is fine. I've had, innumerable ultrasounds. So what could be wrong? They can't see. Well, with a regular pelvic ultrasound, we really can't see the inside, what's truly going on in the lining of the uterus. And that's what either the saline sonogram or a hysteroscopy is for. Now, in my opinion and Brandis's opinion, for folks that are moving forward with IVF, if you haven't done an HSG, the hysterosalpingogram, the dye test, we don't recommend, we don't feel like you need to do an HSG. An HSG is a test that's really designed to show the fallopian tubes and the shape of the uterus. Well, if we're doing IVF, we're not going to be using the fallopian tubes. They aren't really part of the equation. So I personally do not order an HSG for patients that are moving to IVF, because the status of the tubes is really not what's critical. So hopefully I was able to answer that question for you there. Ashley Jordan Paler here says, at my previous clinic, they found micropolyps in the uterus and prescribed doxycycline for 14 days. Would that clear them, or should I repeat testing before an FET? Can micropolyps cause implantation failure? So a polyp is a finger-like growth of tissue that usually either sticks up like a tree trunk or it hangs down like an icicle. It's a fleshy growth on the inside. And what it's doing is that it is, as I like to say, it's taking up valuable real estate inside the uterus that can otherwise be used for an implantation. It's also often a sign that the lining itself is unhealthy, that there's something wrong with it, that you really have literally grown a patch of weeds in the lining of the uterus. And so what we want to do is take a weed whacker to that, clean that thing off. That polyp, if you think about it literally, it can act like a windshield wiper and, sort of bat an embryo right on out of the park when it's trying to implant there. It's taking up real estate. Micropolyps, as you call them, are instead of one big, well-formed polyp, are a bunch of little polyps. The fact that they treated you with doxycycline says that they believed that those micropolyps were related to chronic endometritis, meaning to say a chronic inflammation in the uterine lining. And so sometimes you can think about it, if your skin is all inflamed, it gets red, and maybe it gets dry and flaky. Well, the same thing might really happen in the lining of the uterus there, that if it's all inflamed, that you may grow a bunch of little, like little excrescences that are sort of sticking out from that lining. So their hope there was that those polyps would go away. In your situation, since we didn't do that evaluation, I would sure recommend you get that looked at again, really before you go and do an FET, because if they didn't remove anything, if all they did was a little biopsy and left a bunch of polyps behind, thinking, well, this is inflammatory, so hopefully antibiotics will take care of it, I'd sure like to know that mechanical issue is not still sitting in that uterine cavity waiting for your embryo to come along so that it can go, you know what I mean? So I think, given how precious these embryos are and how much we invest into making the embryos, seems to me to be the best idea to have that evaluated again. Oh, let's see what else we got going on here. Kelly is here on the Facebook side. And Kelly says, we were told we probably would not be able to do a fresh, but they said today we could. So we plan on that this week sometime. I heard that frozen is a higher chance of working. So I really hope that it works. But yes, I guess Kelly here is answering Ashley, who wanted to do a fresh transfer, but decided to hold off. Considering how I'm feeling, I'm thinking some time to recoup will be beneficial. Well, I think you're really onto something there. And so, again, your ovaries really responded well to the medication. And when that happens and you're really not feeling great, that ought to be one measure of your body telling you that this is not the best time to implant a pregnancy. All right, let's see what else we got going on here. Jessica says, what if you're a travel patient? What if you're a travel patient and you already have done all the testing prior to the consult, could you then, after the consult, start your medication ordering and stims? So yes, to some degree, yes. There are a lot of folks who come into our consults already having all the testing done that we want or need. And if that's the situation, it just saves you some time. It still takes a little time to get the global travel team to connect with you, to set up that monitoring, to get your flow sheet created. But really, in that situation, hopefully by the time you get your next period, you ought to be able to start your stims. Now, if that next period is expected 3 days later, that probably won't work. It's generally a minimum of about 10 days is what's expected. So hopefully that gives you some realistic expectations there. Oh, let's see what else we got going on here. Ivo Pink Shop. Ooh, I like the sound of that. Hopeful in 2023. Hello to Erica Walden and IVF Done My Best. My friend BJ Pumping. Lisa Mullins. Oh, a special hello to Zenny in Miami. Thank you so much for being here this afternoon. And let's see, I have a positive. This comes from Kishario. I have a positive pregnancy after a Sarasota transfer. Congratulations. Currently 6 weeks, but dealing with low and slow betas. Any major concerns with low betas? Kishario, I'm not so worried about low betas as much as I am about how they are going to change over time. So we expect to see that a beta HCG should double in 48 hours because 2/3 of normal pregnancies will double in 48 hours. And by the time that beta gets to about a 1500, we ought to be able to see a pregnancy that is inside the uterine cavity. So we can diagnose what we call an intrauterine pregnancy, and we don't have to worry anymore at that point about an ectopic or a tubal pregnancy. So there are some people who start off with low betas. And I have had, I can't even tell you the number of people who I've known over the years who have told me, my first beta was really low. And so they said, just forget about it. And I say, well, why would you forget about it? Because, there's zero harm to continuing your meds for another couple of days and repeating that number again, because it may be that the implantation happened a little later than we expected it, the timing may be a little bit off based on, we place an embryo inside and expect it to function in the way that we expect it to function, but they don't always read the book. So, it can start low and still be absolutely a normal thing. However, when we see that those betas are not rising appropriately, that to me is more of a concern. So that is, I'm sure, what they're watching out for. Dr. J says, do you believe diet, supplements, and acupuncture can lower FSH levels and lead to successful egg retrieval? Well, so there is some pretty good evidence there, doctor, that says there are an evidence-based supplement protocol for egg quality and egg reserve that I have seen improve people's AMH numbers, drop their FSH numbers, and absolutely improve their egg quality. So yes, I do think that acupuncture can help with that. Acupuncture is particularly good for blood flow type issues and for balancing some hormonal things. And so definitely, I think that there can be a difference there. Dr. Kiltz is a firm believer in diet making a difference for you. I'd strongly encourage, and that's keto. It's high fat, moderate protein, and low carb. So I do think that that is something that's worth looking into. He talks extensively on keto and carnivore, and really is the source for understanding the effect there. Let's see. I hope you can still hear me on my Instagram side because it looks like a lot of folks are dropping off. So I don't know if you can still hear me there. So we'll take a look over here back to the CNY Instagram side. Do you recommend PRP in low ovarian reserve patients? This comes from Carolyn. I would say yes. I feel very strongly that I've seen some really make a difference intra-ovarian PRP, and so that's basically where we take your blood, separate your body's healing components and place that tissue directly into your ovaries with your own growth factors, healing factors, tissue factors. And I have seen that make a difference in terms of egg quality for sure. Now, is it going to make a difference in the number of eggs that you have in your ovaries? The answer to that is no, unfortunately. We're born with all the eggs that we'll ever have. But no matter how many eggs you have, the egg quality is where we can really seek to make a difference. We can't change the number of eggs because, again, you're born with it, but the quality of the remaining eggs is what we can sometimes change with intra-ovarian PRP. But I want people to have a realistic understanding about what that can do. If you are 50 years old, for instance, there's going to be very little that we're going to be able to do that's going to be able to change the quality of those eggs. Now, there are some experimental things with mitochondrial DNA transplants and so forth, but at this time, not a whole lot we can do in that scenario. But for some people, yes, I do think intra-ovarian PRP truly makes a difference. Let's see what we got going on here. Stacy is looking forward to her appointment on the 9th. Can eating fresh ginger affect estrogen levels? Because my estrogen level dropped from 116 to 46. I don't think that I am not familiar with ginger being a cause of low estrogen, but and I would have to think that you'd have to eat an awful lot of ginger to have that kind of an effect. Now, truthfully, the estrogen levels don't make as much. It depends on kind of where you are, but I don't worry too much about estrogen levels. Estrogen levels tell me a little bit about how your ovary may be responding to medications. But at CNY, we use letrozole so frequently in stimulations, and letrozole causes the estrogen level to drop. That it's hard to really know how to interpret that, and so kind of depends on your scenario there. But I would think that you would have to eat an awful lot of ginger to make that go down. Escobar La Chula says, if you have a canceled egg retrieval after taking both Luprons and HCG, when do you ovulate, and is it guaranteed? Well, I'm not so sure I understand the question. So you took Lupron and HCG, which are triggers, and these triggers are what we use to tell the ovaries it's time to get ready to release an egg. So after in an IVF stimulation, when we have built up some follicles there for you to get we've stimulated the ovaries to try to get them ready to release an egg. I'm gonna just take that thing out there. Hopefully you can still hear me here. I don't know if I might have lost some audio on this Instagram side. So I took a microphone out there and tried a little differently. Let's see if that makes a difference. So you're stimulating, and then we give you the trigger shot so that we can tell the eggs that we're ready to come for them. And then typically 35 hours later, we do the retrievals. So I guess you're saying you canceled your egg retrieval after you had done your trigger. So when will you ovulate? Well, typically probably within 36 to 42-ish hours. I'd say 36 to 48 hours is probably the safe bet there when you will actually release those eggs. So there's a couple of different parts that go into the process of releasing an egg or of ovulating. So the egg, if you think about it, is like it's attached to a little stalk inside the fluid-filled sac. Okay, and so the first thing that we want that egg to do is to be released from the stalk and float free inside that little follicle, so that when we place a needle inside of it to aspirate the fluid, that the egg comes out with it. If it's attached to the little stalk, then it's going to stay behind. The second thing that happens in nature is that, well, that egg is released to float around free inside the follicle, but then that follicle acts like a squirt gun and it squeezes that egg out. It gets released, and that's the portion that we call ovulation. So will you ovulate after a trigger? Yes, you will. It will. Is it guaranteed? Well, I mean, I don't know that anything in life is actually guaranteed, but physiologically, there's no reason that it shouldn't happen. And I'm not really sure that there's a good way that it wouldn't happen, if that makes sense to you. So hopefully that helps you there. Let's see. Lisa says, I had an initial call and the doctor said to take CoQ10, but I noticed there are two types. Not sure which one to take or both. Okay, so CoQ10 is probably the most important supplement next to a prenatal vitamin that you can take in terms of egg quality. There is a form of CoQ10 that is known as ubiquinone, or in some cases ubiquinol. The ubiquinone form of CoQ10, if that's the one that you have, requires that you take 400 milligrams of the CoQ10. If it is not the ubiquinone form of CoQ10, then you take 600 milligrams of that CoQ10. So that's how that works. And I think that's probably what you're talking about there. All right, let's see what else we got here over on the Facebook side. Hello to Haley. Haley says, what is Immune Protocol 3? I'm doing that with a modified natural. Next transfer. Do you recommend anything before this transfer? The first transfer failed. It was a medicated cycle from a PGT normal embryo. So Haley, what I want you to know is that a PGT tested embryo gives us about a 60 to a 65% probability of a pregnancy. When that doesn't work, and it's not 100%, because let's say it's a 60% chance, well, that means that there is a 40% chance that it doesn't work. All right, well, what are you going to do then? Well, then you do it again, right? And so when you do that second embryo transfer, it brings you to about an 85% probability of a pregnancy. By the time you do a third PGT tested normal embryo transfer, that is about a 95% probability of pregnancy by that time. So the fact that the first one didn't work doesn't mean that there's something wrong. It's just not a perfect system. And so now that you go to do your second transfer, again, you got about an 85% probability of that working. So that's pretty good. But oftentimes what we do at CNY is that if something hasn't been successful, then we might step up or increase the autoimmune profile in hopes that if there was some autoimmune issue going on there, that we may be able to quell that to some degree, which might improve the odds of the implantation. So what does that really mean? Okay, well, the way I describe it, and if I've talked to you on the phone, if you've heard me say this before, then please forgive me for being repetitive. But there's cake and there's icing. The cake in this matter is where your estrogen and your progesterone are coming from. Where are you getting that estrogen and your progesterone? Are we giving it to you, or are you making it yourself? If you're making it yourself, well, that's a natural cycle FET. If we are giving it all to you, then we are shutting down your body's ability to do it. That is a medicated cycle FET. The cake is the cake, and you can eat a cake without icing. Well, I happen to think that cakes are better with icing, so we add some icing to it. What is the icing? The icing is that autoimmune protocol. And what does it really mean? Well, the guidelines will tell us that in the general population, using heavy autoimmune therapies are just not needed, in the general population. But we do know that the immune system stands in the way of a lot of people being able to get pregnant. And so in that scenario, if we select some method of treating you so that we can suppress some of that autoimmune response, then we are going to be helping some people to get pregnant who would not have otherwise been able to get pregnant. So that's our rationale behind using the immune protocols. There are some clinics who say, absolutely not. We don't believe in that. We don't do anything of the sort. Don't even ask because the answer is no. You certainly in the CNY system have a right to say, no, thank you. I would rather not use those medications. The fact that your first transfer didn't work means that someone felt, well, maybe there was something autoimmune there. So let's increase some of the medications that we give you. So we're talking about increasing the dose of prednisone. We've got low dose naltrexone. We've got Lovenox. We're adding usually a Prograf or Plaquenil, which are anti-rejection drugs. We often add Neupogen. We do an HCG wash, and we do an intralipid infusion. These are the things that kind of all go along with the level 3 immune protocol. So the thinking is that, well, maybe there's something autoimmune in your situation. And so if we can turn down the volume on that autoimmune, then maybe we can increase that probability of a positive pregnancy test. Let's see here. Courtney says, no, HSG is the best news ever. I had it done at a prior clinic, but hallelujah. Because it's hallelujah for the new IVF, ladies, because it's brutal. Well, it is. I have to say that HSG test is my least favorite thing to do to people because it is an uncomfortable test for sure. I really I try to pride myself on doing it gently enough that it is not full of torture. But even in the best case scenario, it's distending the uterus, which is crampy and uncomfortable. And especially if the tubes are blocked or there is a tubal spasm, that fluid may have no place to go, and so it just distends the uterus, and that can be that can be a very uncomfortable thing. I personally believe that the value of the HSG is limited across the board, but it is certainly something that for folks who are planning to do something like an IUI or who want to do timed intercourse as part of the evaluation to say, why am I not getting pregnant? An HSG is useful. It's a useful test because we need to see that the tubes are open. But what we know is that in the HSG, when it shows us that the tubes are blocked, up to 60% of the time, 6 out of 10 times, the problem is not a blocked tube. The problem is a tubal spasm. And so if you repeat the test a month later, you may find a tube that showed it was blocked is now, in fact, open. Problem is, nobody wants to repeat that test again because it doesn't feel good and it's expensive and it's an exposure to radiation. So, in my opinion, for folks who are moving into doing IVF, it really isn't all that necessary. There are a lot of folks who will, excuse me, just a moment. There are a lot of folks who will recommend an HSG test to make sure that you don't have a hydrosalpinx or a fluid-filled fallopian tube. Well, I understand why people would think that that would be a good idea, but in fact, even our sort of major number one reference guide, which is a book that's by Dr. Spiroff, Leonard Spiroff, tells us that the HSG is not the preferred test for diagnosing a hydrosalpinx. So I do not think doing an HSG to make sure you don't have a hydrosalpinx is a good idea. And I will never recommend it as such. So there you go, Courtney. No HSG necessary. Okay, Heather says, going to try to do another transfer with our gestational carrier soon. We had 2 failed transfers with PGT-tested embryos. Would like to do a natural cycle. Would she just need to do LH strips at home? If so, how often? And when would the transfer be if we have a day 5 embryo? So when doing a natural cycle or a modified natural cycle, we still, we say it's natural, but that doesn't mean that we don't monitor the crap out of you, quite frankly, because, we still want to look at those hormone levels. We still want to know everything that's going on, because if the body has a little hiccup and it doesn't do what we want for it to do, then we're going to treat that. So natural doesn't mean, hey, good luck to you. Let us know when you have a birthday party. We're still monitoring everything. It just tells me that the where the hormones are coming from, that they're coming from you instead of coming entirely from the outside. So that's what the natural cycle is. So I would still recommend that we monitor. Um, and when we see that the follicle is of a mature size, that we can trigger the ovulation. What's the advantage of doing that? First of all, there is no disadvantage. There's no decrease in anything or worsening of any kind of outcome. But in fact, what happens there is that when we see that that follicle is mature and we trigger the ovulation, it puts a little bit of control back into your hands in terms of the logistics of that timing, the logistics of that transfer. So in your situation, it's going to be 6 days later after the trigger that you will have your embryo transfer, because that's the amount of time of progesterone that your body needs to get that uterine lining where it's supposed to be. 6 days after the trigger. Plus, when we can monitor and see how the egg is, or rather, how the follicle is growing. When I say control over the logistics, well, then we can just sort of make sure that you are not going to be ovulating and then needing to have a transfer on a Sunday, because our clinics aren't open on Sundays. So it gives you a little bit more control over the timing. It also really helps, in terms of planning travel and that sort of thing. So there are some people who prefer to wait and ovulate on their own and just do LH strips at home and tell us about their own ovulation. But if that happens on a Monday, then that means that your transfer would be on a Sunday, and then we're not doing it. So it really, monitoring that and triggering gives you a little bit more control. Hi to Jessica. This is another Jessica. We got a lot of Jessicas on board tonight. Thanks for being here, everybody. By the way, it's about 10 minutes until the top of the hour, so we're going to see if we can't get all the rest of these questions in. Let's see. Jessica says, I'm finally ready to start my cycle, and I got COVID in early December. Now my period is 10 days late. I have another cold. Will this affect my retrieval? Do I push everything back? So I will tell you that, yes, I do believe that having COVID has an effect on your response to medication and on your egg quality. And I know this because I have seen it happen in some very dear friends who were doing treatment, planning to start a cycle, got COVID, and we saw a not insignificant decrease in the way the follicles look and in the number of follicles at the beginning of the cycle. So much so that then even, a couple of months later, we waited 90 days after COVID, and saw really a dramatic improvement in what we call the antral follicle count, or the number of follicles in the ovary at the beginning of the cycle. So yeah, my recommendation is that if you can hold it off, I probably would. I don't know that there is great, published data on that, but I personally have seen it empirically innumerable times. And so I feel pretty strongly about it. So I know that's probably not the news that you were hoping for, but take it for what it's worth. Okay. Looks like Maya is here. I am doing a transfer on Thursday. Should I be preparing for this other than my IVF meds? I'm talking about food or drink or anything. So I would say, number one, you want to keep yourself as well hydrated as you can be. Hydration is important. Number two, keto does make sense at this point because it's high fat, moderate protein, low carb. The high fat is anti-inflammatory, and we know that the carbs are pro-inflammatory. So by diminishing your carb intake, you are probably doing yourself a favor. Let's see, Lorpu, if I believe is what that says. Lorpu Gabriel Lacey. Are there any testing you would suggest I do before going into another FET after a miscarriage? I had a tubal removal, polyp removed, and a DNC last year prior to my transfer. Well, so, the thing I'd like to know about is there When was the last time your uterine cavity was evaluated? Because once a year, I think it's really important that you make sure that there's nothing left inside, no debris from the prior miscarriage, no scar tissue from the DNC. And if that hasn't been done recently, I think you should be doing that. That kind of testing. There are some supplements that are recommended for embryo transfer, part of the evidence-based protocol. Those supplements, prenatal vitamin, CoQ10, vitamin D, vitamin E, and L-arginine. Those come from the book. It starts with the egg. And so these are things that I would recommend. But other than that, as Heather says, you can otherwise pretty much eat and drink like normal. Angel Collins said, Dr. Fink, you did my transfer on December the 18th and I'm pregnant. That's fantastic. I'm so glad to hear that. Thank you. Let's see what else we got going on here. Aaron is here. I have a blockage in my tubes. I moved from Minnesota to use this clinic. Well, that is, when you have when your tubes are blocked, that's a problem because that means that there is no highway for the sperm to be able to meet egg. And that means IVF is the necessary procedure in order to get pregnant. So glad to have you. Let's see what we got here. I'm an IVFing unicorn. Thank you for all you do. And thank you for your very cool handle there. September Everything. Is it safe to transfer frozen embryos to a different clinic? The answer is yes, it is safe. So embryos are frozen in what's called a cryolock. And the cryolock is like a little tube that goes into a big tank of liquid nitrogen. And that liquid nitrogen keeps everything frozen solid. The process of shipping embryos is pretty straightforward. And has come a long way because now we know that we don't want to keep anything, out of. You've got to take it out of its house, and you have to put it into a shipping house, if you will. That transfer takes place very rapidly. If they're out for even a short period of time, they can start to thaw, and that can damage the embryo. So that's something that we know how to do in the modern industry of fertility. That we know how to take an embryo out and put it into its transfer tank and to ship it off. Now, once it's in that tank, it typically would stay good for probably about 30 days. So even if FedEx has storms in Memphis and those tanks end up stuck in Memphis for an extra 2 days, it's probably going to be okay because the liquid nitrogen maintains that temperature constantly frozen. They're not opened up. They're not, if you got liquid nitrogen on your skin, it would cause a terrible burn. So nobody's messing with any of that stuff there. So yes, I would say it is safe to transfer embryos either to us or from whatever one location to another, as long as these are both places that know how to do it. And if you're talking about fertility clinics, transferring embryos is something that happens really every day. Oh, let's see. Can't wait for my consult, and we can't wait to talk to you either, my friend. Let's see. Rakinar was here today for the transfer, and I didn't even see you. Oh, my goodness. Lynn's 2528 says, I was diagnosed with endometriosis over 10 years ago, and I had ablation, life-changing surgery. But since I had it, does this mean that the concern of endometriosis is still there? You have one living child. So, once you have endometriosis, we can surgically treat endometriosis, and hopefully that improves lifestyle kinds of problems like pain. But it's not typically something that will just disappear. So oftentimes the presence of endometriosis 10 years ago means that we have to be concerned about endometriosis now. You can do another laparoscopy. There is a non-invasive test for endometriosis called Receptiva. Sometimes we might just empirically treat you for endometriosis, but depending on the number of embryos that you might have, let's say that you ended up with, miraculously, you're planning to do IVF and you got 20 embryos that you created here. Well, maybe you just want to go ahead and transfer an embryo and see what happens. If transfers are not working, then I would generally recommend you don't need to really be retested for endometriosis, but I would go ahead and treat under that scenario. And that's usually 60 days of medication, either in the form of Lupron, which is an injection, or there's two different types of oral medications that we can use, either Oralisa or one that's called Myfembree. 60 days will improve the odds of your transfer being successful. Latoya is being seen in Sarasota tomorrow. And Aisha asked, do you continue shots after retrieval? I am doing an FET. So I guess you mean the progesterone and oil shots. If you're getting progesterone and oil or PIO shots as part of a medicated embryo transfer protocol, then unfortunately, you got to stay on those shots until really about 10 weeks of pregnancy. So, gosh, we are going to run out of time here tonight. It is so great to see everybody for the new year, and thanks so much for being here. Every Tuesday evening, we do the same thing at 4 o'clock Mountain Time, and that's Fertility with Fink and Friends. I am Fink, and you are friends, and just like the sign says behind me that comes from my dear friend Jody from embryology, and that is that fertility is not the book of your life. It is merely a chapter. And what we're here to do is to help you to rewrite that chapter. So until next time, thanks so much for being here. God bless everybody, and good night.